physically look at. Oops.
Oh.
I'm going to say got it.
Okay. So today we are going to learn about juvenile idiopathic arthritis, learning from top experts in the field. But before we begin, I'd like us to participate in a quick icebreaker so that we get to know one another and break the tension that is in the room right now. So I'm going to post the link for the icebreaker. So once you see it in the chat, just click on it. I'm sharing it. So there goes the link for the icebreaker on Mentimeter. So what you're going to do, you're just going to click that link and the link should take you to the questions. Just three simple questions that you should be able to respond to. Yeah, so waiting for your responses. Nice. Enthusiastic. How are you feeling today? Empowered, hopeful, eager. Very nice, very nice, very nice. Next question. Lausanne. I don't even know how to pronounce that. Kakamega, Tintigua, Kiambu, Nairobi. Any more responses? Can anyone guess where Lausanne is, or it's Lausanne? If you can guess, please tell us in the chat. Tell us where the city, in which country that city is. Are you ready? Are you ready? Are you ready? I can only see 2 responses. Does that mean we are not ready for the session? Nice, 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 nice. Okay, so since we are ready, we are going to begin. For those who have just joined in, my name is Tracy Mwiti, Program Coordinator at Hope Arthritis Foundation, and I'll be your moderator for the session. I'll quickly go through the house rules once more for those who have just joined in. So please keep your microphones on mute unless you're speaking. And if you'd like to speak, just use the raise hand feature and we're going to give you an opportunity to speak. But you're allowed to have your video on if you're comfortable that way. Then use the chat box for any questions and comments during the session, and we're going to address all the questions at the end of the session. So thank you so much for participating in the little exercise. I hope you're now ready for the session. But before we get into the presentation, there's just one small task that I would like us to do, and that's the pre-course assessment. So this is just to help us gauge your understanding, your current understanding of juvenile arthritis. So please Please take a minute or two to complete the pre-course assessment. I'm going to share it in the chat. So this should take less than 5 minutes. Whatever you know, just complete the pre-course assessment. Don't feel
Diana?
discouraged.
Yeah, I did it.
Please, let's have our microphones on mute. So the link I have just shared on the chat is for the pre-course assessment. It's just a short quiz to help us understand your current knowledge on juvenile idiopathic arthritis. It should take less than 5 minutes, so I'm going to give you 5 minutes to complete it. Don't feel discouraged if you don't know the answer, because that's why we're there. Just make sure you just put something there. So as we take the pre-course assessment, I'd like to inform you that we are going to be issuing certificates for the successful completion of Hope and Healing Masterclass. And so there are a few requirements that you have to meet for you to get a certificate. So the first one is the pre-course assessment, which you're currently doing. So that is going to be crucial for you to get your certificate. Then you also have to attend the 2 live sessions for this course. So this course has been split into 2 parts. Part 1 is what we are having today, where we are going to look at the signs, the symptoms, the investigations, and medications. So the next session, part 2, is happening next week on Saturday. That is 21st at 11 a.m., still on Zoom. And then after attending the 2 sessions, you have to do another assessment, post-course assessment. And then finally, you'll get a general feedback form just to give us feedback about how the course was. So once you are able to complete all those requirements, you're going to get your certificate of participation for the JIA Masterclass. So we'll be sharing all this information with you on email, so do not worry about memorizing it. We are going also to share it on WhatsApp. So I'll be posting the link to our WhatsApp community in the chat. Once you see it, feel free to join our community. We'll be sharing our updates there. So I hope you've had enough time to complete the course assessment. So without much further ado, I'd like to introduce our first speaker. Our first speaker for the day is Dr. Angela Migoa. Dr. Angela is the CEO and founder of Hope Arthritis Foundation, an NGO that advocates for holistic care for children with arthritis. She's also the founding president of PAFLA, the Pediatric Society of the African League Against Rheumatism. She's also the immediate past national vice chair of Kenya Pediatric Association and an assistant professor and pediatric rheumatologist at Aga Khan University Medical College. In addition to that, Dr. Angela was recently declared winner of Top 40 Under 40 Women by Business Daily in 2021, and also featured in the Global Lancet Journal for her advocacy in pediatric rheumatology. So Dr. Angela, the floor is yours now. Please feel free to take over.
Thank you, Tracy, for that kind introduction. And in a special way, I just want to appreciate and honor each and every one of you who have logged on for this session. And also grateful to my fellow panelists and speakers who will be presenting with me. So my task this morning is to empower everyone who's logged on today to know what are the signs and symptoms of juvenile idiopathic arthritis in children. And this is a form of chronic arthritis in children. And thereafter, my colleagues will proceed and I will be taking questions after the 3 of us have presented. So as I mentioned, the objective is to really familiarize guardians, on how can you identify children you suspect could have arthritis. And this is important because we at Hope Arthritis Foundation are relying on you to partner with us to identify these children early, because they spend more time with you, and we know that when they are brought forward early in time, then we're able to offer care and support and reduce some of the complications and long-term disability in them. This is going to be some of the things I will be discussing. Just to appreciate what's the history of chronic arthritis in children, JIA, how it's classified, and the clinical features. So those who attended some of my sessions, I like to present this case because I feel it really depicts the challenge in our context. So this was a 6-year-old girl, we'll name her Halima today, who came from one of our northern frontier countries at the border of Kenya and Ethiopia, Moyale. And for about 2 years, she had this pain and swelling of her right knee, which she had been going to several local health facilities, but it was so progressive to the point it was in a position that was completely bent, so she wasn't able to walk. And ultimately, the solution that they were offering her was an amputation. But her father was determined to save the leg of his daughter, and he traveled all the way to a mission hospital near our capital, Nairobi, called Kijabe. And when they arrived there, they were not sure what was the diagnosis, but they recommended she get a rheumatology review. So she came to our facility, we diagnosed the arthritis, we were able to treat her, and we were able to save her from having her leg amputated. So this is why we really value you as the guardians, because we believe in Hope Arthritis that when you, the guardians, are empowered, then it is much easier to get these children the help that they need and to avoid unnecessary or harmful interventions. So, contrary to what people might think, actually, juvenile idiopathic arthritis has been known for some time. You can see it was first described in the late 19th century by a pediatrician in the UK. But it is only after the Second World War that an institution was set up to be able to offer specialized care for children with arthritis. And hopefully this is something we can be able to achieve in our setting sooner than later. Definitions are important so that we are clear what really is juvenile idiopathic arthritis. So juvenile comes from the fact that this is beginning in the population of children who are younger than 16. So when the symptoms begin when they are 16 years or younger, then that's already one checkbox. And they should have arthritis that lasts for at least 6 weeks. And what's the definition of arthritis? When a joint is swollen or painful and difficult to move, those are the signs that are suggestive of arthritis. And what is important is to ensure we rule out all other causes of arthritis. And my colleague, Dr. Rafaela, will be sharing with you what are some of the other possibilities. And the example I like to give parents is, when you say a child has arthritis, it's like telling someone your blood level is low. If your blood level is low, the question is, why is your blood level low? Is it low because you haven't eaten enough? Or is it low because you're bleeding from somewhere? Is it low because your bone marrow is not working well? So when we see children with arthritis, we are always trying to understand what is the reason behind it. So that's why we must exclude all other causes. And there are 7 types of juvenile arthritis. So when children come to us, this is what we are trying to rule out or trying to determine which type. And the one that's mentioned there, first systemic, this one normally comes with a lot of fever. So the children have painful swollen joints and fever that doesn't respond to any medication. You could also have a situation where the child has 4 or less joints. So that's what we call oligoarthritis. And if it stays like that for 6 months, we call it persistent. But if after 6 months they add more joints, then we call it extended. It has extended beyond the 4 joints. Then we have a case where there could be 5 joints or more involved. So we call that polyarthritis. And this is really important for the guardians. It is only when a child has 5 or more joints that we should actually ask for the rheumatoid factor. That's a very common test that is asked for. But it should only be asked when there's evidence that a child has 5 or more joints affected. Sometimes children have arthritis and also have a skin rash we call psoriasis, which looks like a silvery skin rash or a lot of dandruff. We call that psoriatic arthritis. Other times, not only do they have painful swollen joints, but at the point where muscles attach onto the bone, there's also a pain there and inflammation. Inflammation is that swelling and tenderness. So we call that enthesitis-related arthritis. And then we have undifferentiated arthritis, where it doesn't really fit in any of these groups. And so when we are diagnosing children with juvenile idiopathic arthritis, we are trying to find out which of these 7 does this patient fall in. Now, this is really, really key because when a child has a painful joint, we're always wondering, is the primary problem that there's arthritis, or is it that there's a problem with the alignment of the structures of the bones and the muscles, which you would see in the case of a fracture or a sprain. So in that case, then we call those mechanical symptoms, right? But when there's swelling because of arthritis, then we call that inflammatory. And the thing that really helps us distinguish that is history taking, right? Where we have to really exercise the art of listening. Hear out what the guardian, the parent is saying, because then this empowers us to know where the problem is likely to be. And it is only after listening to what the guardians are saying, plus the physical examination, that forms about 80% of all the information we need to make the diagnosis. Then the other 20% comes from the tests. So what are the key things we look out for, which even for you as guardians, if you ask your child or if you make an observation, you will be able to know that this is likely a problem with how the muscles and bones are aligned, or this is likely a swollen joint, meaning that there's arthritis. So when we have problems with how the muscles and bones are aligned, which you would see in a case of a fracture or sprain, there could be history of trauma. The pain that they feel is mainly at the end of the day. The pain also worsens with activity. So when the child is running and walking, the pain is worse. But when they are seated, the pain is better. However, on the flip side, when you have got pain because of arthritis, the pain is at its worst in the morning. So that's when the child has terrible pain. And when the child is sitting and resting, the pain also worsens. But the minute they start walking and running, the pain improves. They could also have stiffness in the morning, and they could have multiple joints involved. So these are some salient things which, as guardians, if you observe, can really empower you to know whether we're dealing with arthritis or not. So here are some pictures. And I think the essence here is to show you about the importance of the power of observation. a lot of what we do in the clinic is to observe. And for here, in this case, you could see that the joints in the middle of this child's fingers, which we call the proximal interphalangeal joints, they do appear swollen. Even before you touch this child, you would have some questions about those fingers. Here you can see that this ankle here appears swollen more than you would expect. So you then begin to wonder whether there could be arthritis on that ankle. You can see here, this is a younger child, and this is very common. You know, sometimes the younger children, they will not, they might not be able to explain to you. So as a guardian, it's important to observe. And you can see here, if you look at these two knees, this knee is swollen. And normally when a joint has arthritis, the child tries to keep that joint in a position where they have the least amount of pain. And often that position is when the joint is a little bit, we say flex, a little bit bent. You can see this knee is not straight compared to the other one. So this is the position of most comfort, right? This is an older child, and you can see again here, this joints of the fingers, which we call the proximal interphalangeal joints, are actually swollen. When we come to the systemic, this is one of the forms of arthritis that can be very confusing because it comes with fever, the joints are swollen, there's also a rash, and that rash tends to come when there's fever. And the minute the fever goes, the rash disappears. And so in our context, you're always worried about infection. So they're often treated for so many infections, so many antibiotics, they just don't improve. And they could have swollen glands, which we call lymph nodes. Sometimes even there could be fluid that accumulates around the heart and even in the lung. We had a child recently who came in and for 2 months was having fever, not responding to antibiotics, accumulated so much liquid in the lung, had to be admitted in the ICU. They had to drain that liquid so she could breathe. She ended up having systemic JIA. So it's unique in that sense. It can have so many symptoms that mimic what we see typically in infections. This is the rash you see in systemic JIA, and they describe it as like an evanescent pink or salmon pink rash. But in our context, it actually looks like quills, the kind of rash that you would see when someone is having an allergic reaction. So you might not see that pink color, but it almost looks like that. This is another case of a child. Actually, she was, her parents and her were living in the UK, and she developed this joint swelling, which they thought was because of infection, but it persisted. And you can see here that knee is already swollen. And if you can, I don't know if it's visible on your end, there are these like puncture marks, which they were trying something called cupping, where you put a small cup and apply pressure and release. And they were hoping that was going to help ease her symptoms, but it didn't work. And you can see the same is happening also at the back. So she was having problems in the spine and also her knee. Now, one other area which is affected in children with arthritis is the joint at the angle of the mouth. We call it the temporomandibular joint. It's normally at around this point here. And it can be affected that now the lower jaw seems to move backwards. We say the lower jaw has receded. This can affect them in their nutrition. They cannot chew. If, for example, they need an operation and they need to be put to sleep, they find it difficult to put in the tube into the lung for them to breathe. So it's one joint we also monitor closely. Now, what are some of the problems that could come up if children with arthritis do not get treatment? And one of the things we are really concerned about, of course, is the burden of chronic pain, the burden of disability, and of course, ultimately, we are always concerned about early deaths in these children. So you can see here in this case that there's a difference in the length of the fingers. At the same time, for the feet, you can see one foot is smaller than the other. And normally what happens in the early stages of the arthritis, because the disease process results in increased blood flow to the area that has arthritis. So that particular area that has arthritis has an unfair advantage, so to speak, of excess nutrients. So it tends to grow faster. But because it tends to grow faster, its capacity to continue growing when they reach teenagehood is shorter. So the other parts of the joints that were not affected, you find later on will surpass. And so you find a child has legs that have different lengths and they have difficulty walking, or like this, the fingers are of different lengths, and even their functionality is affected. Another structural organ that suffers silently is the eye. And the same reaction happening in the joint happens in the eye. The only thing is they do not have pain. So the child will not complain. But unfortunately, they run the risk of going blind. So we've had some children who've come to us blind, only to realize they had arthritis, it was not treated, and they developed the complication. So all our children with juvenile idiopathic arthritis, one structure that we are always monitoring very closely, or organ we monitor closely, is the eye. I think that's it for our presentation, and I'm happy to hand it over to my colleague, Dr. Rafaela, who will now be sharing with us, when we have these children, how do we investigate? Thank you, and back to you, Tracy.
Thank you so much, Dr. Angela, for those great insights. So I'll quickly introduce Dr. Rafaela Calomano, who is a pediatric rheumatologist in Lausanne, Switzerland. She's originally from Italy, and after her medical degree, she moved to Switzerland, where she completed her residency in pediatrics and the fellowship in pediatric rheumatology at the University Hospitals in Lausanne, allowing her to acquire the Swiss title FMH of pediatrician and pediatric rheumatologist. She is also interested in teaching and mentoring and has provided Swiss and international lectures and conferences on pediatric rheumatology. So welcome, Dr. Rafaela. Feel free to take over.
Thank you, Tracy, and thank you, Angela and Charlene, for your collaboration. It was very nice to organize these lectures. It was a really nice adventure. So I'm moving forward on the investigation and treatment in patients with GIA. And just quickly, the objective of this presentation will be to understand which investigation will help the physician to confirm the diagnosis of GIA, to confirm that the child has juvenile idiopathic arthritis, and which are the investigations that should be done once the GIA is confirmed and during the follow-up of those children. And in the end, the treatment strategies that we can use for our patient. So my child has arthritis. What next? So you remember Dr. Migawa was saying before what is an arthritis, but she was also saying that the arthritis, it's a symptom, it's a manifestation of something that is bigger, and we want to understand which is the cause of the arthritis. And juvenile idiopathic arthritis is only one of the cause, and is the one, of course, that we are focusing on. But the role of the physician when he or she sees a patient with arthritis is to rule out other disease that can cause arthritis, and or to confirm the juvenile idiopathic arthritis diagnosis. We can group the different origin, the different causes of arthritis, I like to group that in three big groups that are infectious disease, hematological and or oncological disorders like tumors, and inflammatory disease, where GIA is a part of. So juvenile idiopathic arthritis, we can consider it as an inflammatory disease where the immune system is somehow attacking some part of the bodies, and in the GIA particular is the joint and the eye, as Dr. Angela was saying before. So regarding infectious disease, what we will have, what the physician will have to be attentive is, for example, he or she will think about an infection if the child has a high fever, if he or she is in a lot of pain, so the joint is really painful, is of course swelling. It affects one joint. It's not the rule all the time, but usually it's one joint, and there can be changes of the skin over the joint, can be red, really inflammatory, so there can be redness, and it can be warmer. And in the great majority of times we will find inflammation in the body, so in the blood, sorry. So what we see that is inflamed in the joint, we can see it in the blood as well. Hematological or oncological diagnosis will have to be considered, in particular if children, they have fever that can be also low-grade fever, but it's something that it's been there for a moment there, and there can be other symptoms that are associated with this and the arthritis, like weight loss, night sweat, and by that I mean that the parents need to change the pajama at night, so as much as it is wet. There is pain and there can be swelling, but it can also not be so clearly seen as the image that Dr. Migawa was showing before. But there are also other disease, more hematological side, for example, in children that have bleeding problems. It could be due to actually a bleeding into the joint that cause the pain and the swelling, for example. Or other children that are known for congenital anemia, where the hemoglobin is low, like, for example, sickle cell disease. These can also be associated with arthritis. So we will have to think about these other conditions. And in case in inflammatory diseases, children, they may have fever, especially for the systemic onset GIA that Dr. Migawa was talking about before. Pain of the joint is there. It may be less important than the one that we can have in infectious disease, but it's still there. Patient may have morning stiffness. Children may have morning stiffness, and sometimes I ask them if when they wake up in the morning, they walk, for example, like their grandma or their grandpa, a little bit all stiff, and they cannot move really well in the morning, especially. There is usually not so much of a redness or around the skin of the joint that may be warm, but it's not as much as usually in the infectious disease. And as Dr. Migawa was showing before, it can affect from one joint to several joints. So this will not change the diagnosis, the thinking. So this part that I was showing here, as you can see, it's just clinical part. It's just the part when the doctor is talking to the child, is talking to the parents and guardian to investigate a little bit what's happening, and he or she is examining the child. But already here you can have an idea of what could be the cause of the arthritis, but he or she will have the need to go ahead with some other investigations. For example, the blood work. These will be helpful, for example, to check on the complete blood count, what we call like this. It's basically one of the blood work that check the level of the cells in the blood, the level of the blood, on the white cells, on the hemoglobin, on the platelet, that can help us make the difference between something that is more inflammatory, like GIA, to something that is that has to be checked by hematology and oncology doctors. Inflammatory markers can be checked on the blood work. As I was saying before, you can find inflammation in the blood work as you see in the joint. Not always the inflammatory markers will be increased in GIA, but they can, and definitely they will be increased in patients that have, for example, infectious arthritis. And then there is a number of infectious and hematological and oncological workup that can go from blood work, specific blood work, to check if some bacteria or virus have been around, or on the hematological workup, we can check if there is signs of bleeding, signs of sickle cell disease if it was not known before, or other oncological disease. And they can go from blood work to imaging workup, to other workup where we want to see what's happening in the bone marrow, which is actually where the cells, these cells here, are produced in the body, and that can be low, that can be not functioning well in some case of tumor. Other investigation that will help the physician are radiological investigation. The X-ray has the goodness to be really easily available, and as you can see, the X-ray will show the bones, so these are the bones, but it will not show what's, for example, in between here. There is plenty of ligaments and of muscle around here that actually make the joint. So here, this is the joint space that you can see, but as I was saying before, there are plenty of ligament and muscles all around that will make all together the joint. And with X-ray, we can see what is happening on the bone level as a start, and it can be important. It is important to have an X-ray at the beginning of the disease, so we have what we call a baseline to have a comparison for further reference in the future. And also, as it happens the majority of times, we have to we can compare with the other side. For example, this is a child with arthritis on the left knee, and you can compare with the right knee, for example, and you can see that there is difference. This difference on the bone, it's not happening right away once we have arthritis. It takes some time, but you can see here the difference. So you can see that this bone, it's bigger than the other side here, and it's more transparent. So what happens is that when there is inflammation in a joint, there is more blood coming to that joint with more growth factor. So the bone is going to grow up more faster compared to the other side. But it doesn't mean that it's a healthy bone, because you can see here is more transparent, is a little bit more fragile than the other side. And you can see also as a consequence that the space that make the joint, the space between the bones, it's narrower than the other side. Can I just ask you to be attentive, to close the microphone, please? And so thank you so much. So, and the reason why we do the X-ray in our is to rule out if there is any bone or joint lesion that can help to see if there is, for example, an overgrowth that can be done, that can be caused by, for example, a tumor on one side. But it's also a good reference for the future, as I was saying before, in patients that have arthritis. Another investigation on an imaging technique is the ultrasound. The ultrasound, to differentiate from the X-ray, it will help us to see also the bones, but especially the soft tissue. So I know this image doesn't tell you anything, and it's okay, it's normal, but I will just show you something very quickly. So this is the joint space here, all around here, and actually what you see here, more black, it's the liquid. It's the liquid around, and you can see here this sketch here. It's liquid inside the joint that is caused from the inflammation, and actually it is the arthritis that you can see. And on the other side here, you can see that there is a lot of blood coming, so confirming that there is a lot of inflammation. So this technique will help to see not only the bones, but also all the structure that makes the joint, which structure in particular is affected, because it could also be, for example, this part here, I don't know if you can see it, but it's the blue one here, which is the tendon, that can also be affected. So it's a nice way to look at the bones, and it's not at all invasive, it's not painful, and it's easily available. The other side of it, the lower side of it, if I can say lower side, it's that it requires some sort of expertise in the joint ultrasound. So not all doctors can have the expertise to do this ultrasound. And on the other hand, and I will go on it, I will explain a little bit more what it is, a joint puncture, in a moment, is that this technique can help to guide, in case the doctors, in case she wants to do a joint puncture or a joint injection. We will see what it is in a second. Other radiological investigations that are not really in the first place to do, but I wanted to show you here in this part of the presentation, is the MRI. So is the magnetic resonance imaging, that is, it really helps us to see all the structure around the joint. It will help us see the skeleton, so the bone, the muscle, the ligament, and all the part of the muscle, the last part of the muscle, like the tendons, and see which of that is specifically inflamed or broken, in case it is not inflammation, or if there is other problem. It's not something that we need to do in all the patients, but for some specific joints, for example, on the spine or the jaw, in the what was showing before Dr. Migowa, it can be very, very helpful, because it's very difficult. It could be more difficult to assess this joint in another way otherwise. But when we are in the beginning of the workup and we want to be sure, first of all, that this is a juvenile idiopathic arthritis, MRI can be helpful when the presentation is very atypical. And we want to make sure that there is no other disease involved, and it can help in the process of the diagnosis. This is also an imaging technique that we can use in the follow-up of the patient to make sure that there is no complication happening. For example, the erosion of the bone, when the bone is all so inflamed for a long time that it can be a little bit consumed, reduced in his thickness. However, this technique has, it allows us to see a lot of things, but it has some down points, which is the fact that it's not always available. It's very expensive, and it lasts half an hour, sometimes 1 hour, depending on the zone that we are going to investigate, and where the child needs to be very still. And so for the younger children, it can require sedation. So we have to really choose when we really need it and how to do that. I was talking before about the joint puncture. So always in the first part of investigation of a child with an arthritis, it can be helpful, the joint puncture, when we have, for example, when we are suspecting that this could be an infectious arthritis. So what is the joint puncture? Is when the doctor enters with a needle inside the joint to take some fluid that is, the joint is swollen, so we want to take some of that fluid to have an analysis of that fluid, and this will help us rule out an infection, especially when we do a culture of that fluid. So in particular, we will go to the joint puncture if there is, for example, only one arthritis that is only one joint that is involved, when there is a lot of pain, a lot of fever, there is a lot of inflammation in the blood. So in the end, when we suspect that this is an infection. This technique also requires expertise, of course, from doctors that can and know how to do it, and of course, it cannot be done in patients that have bleeding problem. Of course, we don't want to make them bleed even more. So we will have to ponderate the risk and the benefit of doing this technique. So let's say we have been doing all this workup that we just saw up to here, and we saw that there is no signs of a tumor or hematological problem. The X-ray is normal, or doesn't show bone lesion that make us think of a tumor, for example. There is no signs of infection, or anyway, the infections workup that has been done is normal. No bleeding disorder, no sickle cell. So everything else is negative, is normal. So there we can confirm the diagnosis of GIA. And I come to one of the very first thing that Dr. Migawa was saying before, is that the juvenile idiopathic arthritis is an arthritis that lasts for several weeks, for more than 6 weeks. They start at the age of less than 16 years, and that for whom the other causes of arthritis have been ruled out. So you see, there is not one test that can tell us, yes, this test is positive, okay, we can say this is juvenile idiopathic arthritis. We really have to work out, to rule out all other possible diagnoses. There are actually some specific tests for arthritis that can be done after the diagnosis. They will not help us to confirm the diagnosis, but they will help, of GIA, of course I'm talking, but they will help us to understand which kind of GIA the patient has, and therefore which kind of, if for example the patient has a higher risk of having ocular inflammation, eye inflammation, or a disease that is more difficult to treat. And these are the more important ones that we will rule out, we will check in a patient with confirmed GIA, which is antinuclear antibodies that we will find mostly in young patients, mostly girls, that have asymmetrical arthritis, which means that, for example, we will not have necessarily both hands, both hips, both knees that are inflamed, but it can be right hands, left knee, right ankle, for example. Those patients will have an increased risk of eye inflammation, so we will have to keep an eye on that in particular. Patients that on the other side have rheumatoid factor and eventually these anti-CCP antibodies, they mostly have polyarticular arthritis, which means that more than 5 or more joints are involved in those cases. It's usually more older children, and for those patients we will have to be more attentive because the disease is usually more severe, so we will be attentive and more aggressive in the treatment. And HLA-B27 is a genetic factor that we either have or not have. It's not really a gene necessarily, but it's a little variant that we can have or not. And it's more related to the enthesitis related arthritis, which can lead more to a risk of our involvement of the spine, of the vertebral column. Other evaluation that we will have to do necessarily after we will have confirmed the diagnosis is the eye check, the ophthalmological evaluation. There is a risk of ocular inflammation, as Dr. Migawa was saying before, which is the uveitis. So it's the part of the eye that is beneath the white part of the eye, which is called the sclera here. There are different kinds of uveitis, but you don't need to necessarily know that. This is not really important, but the most important thing is that patients with GIA will have to have an eye check as soon as possible after they have the GIA diagnosis, and the follow-up will have to be regular, depend with a frequency that depend on the GIA, but more or less every 3 to 4 months for the first years of the disease. Because the problem is that this inflammation can be asymptomatic, so the child has no symptoms, no pain, no redness of the eye. In a particular kind of arthritis, it can also be symptomatic, painful and red, but it's just a small part, a small percentage. In the majority, they will have no symptoms. Other investigation that we will have during the follow-up of our patient, of a child with GIA, will be a little bit different depending on the patient, depending on the child. For example, a child that has that is on a treatment, he or she will have to have a blood work regular to check that he or she tolerate well the medication. So that there is no problem on the liver, no problem on the blood level, etc., etc. Patients that are off medication, we will want to check if there is blood inflammation, even if when we see them regularly, especially if the disease is relapsing, if they have a flare, so if it comes back. And for all patients that have active diseases, so a disease that is still ongoing, or that they are on medication, it's a little bit more difficult to treat, we will want to check that the bone remain healthy. So we will want to check calcium, phosphate, vitamin D, to be sure that they continue to be healthy. And there will be a session, I think, next week about the importance of sport, of physical activities. So I'm going to the last part. I'm reaching the last part of the presentation when I'm talking about the treatment in the juvenile idiopathic arthritis patient. So all those patients will have to start with like the first treatment, the first line treatment that we'll give to these children will be non-steroidal anti-inflammatory drugs, like, for example, ibuprofen or naproxen, diclofenac. There are a number of that. This medication will reduce the inflammation and the pain, and it's the first line treatment that will help on one side to relieve the symptoms, because they will reduce also the pain, but in some case they can also be effective to control and sufficient to control the disease, and we will not necessarily need to go over other medication. However, this is not the case all the time, and despite NSAID well taken, we may need to go over other medication and other technique. So one of these is the joint injection. I was talking before about the joint puncture to analyze the liquid to see if there is infection. So the joint injection is similar, the technique is the same. We go inside the joint with a needle, and if possible, we take some fluid, that will be increased to analyze, but as a treatment method, we will inject steroid inside the joint, inside the synovial space, so this part here. So corticosteroids are really one of the most powerful anti-inflammatory drug that exists today. It's a very old medication, but it is still very effective. And the good thing of using the joint injection is that it's very effective, and it can be used in cases where there is only few joint affected. Other in cases where joint, yes.
Sorry to interrupt. Just reminding you about the time.
Okay.
Yeah.
I will go quite fast. I don't have many slides left.
All right. Thank you.
Thank you. Sorry for taking time. So in case the joint injection is not effective, or in patients that have more joints that are affected, that we cannot do the joint injection, we will have to go ahead with immunosuppressant medication in order to calm down the immune system and therefore calm down the inflammation. So one of that is the methotrexate that reduces the reproduction of immune cells and of cells, and then reduce the immune system activation. This is usually given once per week, can be oral or by subcutaneous infection, but takes some time to be effective, usually 1 to 2 months. In case the methotrexate is not effective enough or it's not well tolerated, we can use other medication like TNF inhibitors that block one molecule that is very increased in GIA. It's also an immunosuppressant medication, and it's given by subcutaneous injection or intravenous injection at the hospital. And it is more rapidly effective than the methotrexate. Other medication that we can also use in those patients are other blocker, like for example IL-6 inhibitors, tocilizumab. It will block IL-6, and it is given by subcutaneous or intravenous injection. And it's also the goal of this medication to block the immune system that is too much activated in these patients. This medication, the abatacept, will go against lymphocyte C, a kind of white cells, but is unfortunately not available for the moment in Kenya. So I will go faster on that, and I will go more on the JAK inhibitors that you do have in Kenya, that block the immune transmission within the cells, and they can be taken by oral administration every day. The rituximab is a medication that will go against other cells that are really active in this disease, but these have to be given by intravenous administration, given every 6 months at the hospital. And last one is our IL-1 inhibitors. I just wanted to mention this one because we use this medication there for the systemic GIA in particular. And it's also by subcutaneous administration that can be given every day to every 1 month, depending on the medication. Sorry for taking a little bit longer of the time I had, and we thank you for the attention, and we will take the question after the end of all the presentation.
Thank you. Thank you so much, Dr. Rafaela, for that detailed and informative session. So the last speaker for today is Charlene Hopper, who is a pediatrician nurse in the rheumatology division of the Montreal Children's Hospital in Canada. Her nursing experience spans over 35 years, practicing in various settings, the last 20 in pediatric rheumatology. She studied in Canada and holds a Bachelor of Nursing from the University of New Brunswick and a Master of Science in Nursing from McGill University. Charlene, welcome. The floor is yours now.
Thank you. And Tracy, can I ask you to put my slides up? I'm seeming to have difficulty.
Okay. Just give me a second.
Thank you. So I'm very happy to be here today and to share some information with you. And I'm looking forward to hearing about your experience as caregivers during the question and answer period of the presentation. So the objective of this lecture is to talk about the spectrum of medications available to treat JIA, monitoring their safety, also to talk about eye care and blood tests. Dr. Carlo-Mango and Dr. McGowan have talked about signs and symptoms of JIA. I'm going to be talking about taking medication. Sorry, I've just told you what I'm going to be talking about. Next slide, please. Arthritis is treated with the goal of completely getting rid of inflammation in joints. And we see inflammation in arthritis as swelling, warmth, stiffness, and pain. Juvenile arthritis is what we call an autoimmune condition, which means that the immune system is making a mistake against itself and causing the inflammation that we see in the joints. Medications are one of the tools that healthcare providers can use to manage the arthritis. When the inflammation is gone and the child's pain and swelling go away, they can pursue activities they enjoy, which is very important. Not only having no pain and swelling, it allows the child to be active, but by controlling the inflammation, we're preventing damage to the joint and allowing the child to have a good quality of life. Next slide. Healthcare providers are experienced in choosing the right medication for the right situation. And like with many conditions, there's a recipe or steps that they follow for introducing medications. The first step is the introduction of the class of medications called NSAIDs. NSAIDs or non-steroidal anti-inflammatory drugs are often used as a starting treatment, and sometimes they're the only treatment that's needed for managing the arthritis. NSAIDs help with pain and inflammation. One rheumatologist I know refers to this as putting out the fire of the inflammation. This image shows how NSAIDs work, and I just want to focus on the red X that's in the middle. And it shows that they work by blocking the production of a protein that causes inflammation and that can also cause fever. You probably recognize some of these names, and Dr. Carlomagno also mentioned some of the names. NSAIDs are available as pills or liquid. It's important to remember that they should always be taken with food, as they can irritate an empty stomach. So if they're taken twice a day, they would be taken with breakfast and supper, 3 times a day with breakfast, lunch, and supper. Sometimes we forget a dose of medication because we get busy, and that's okay. It's important to remember just to go back to your regular dosing schedule and not double up on doses. NSAIDs can take time to help. Some children have less pain after a few doses, but others will need a number of weeks for the medication to work. So it's really important to not say after a week or two, oh, the medication isn't working, I'm going to stop it. Keep on going and try to continue until you go back to see your healthcare provider. Paracetamol is from a different family than NSAIDs, and especially early in the treatment, it can be helpful for managing pain, so it's okay to take with the NSAIDs. It's important, however, to remember not to take any 2 NSAIDs at the same time. The NSAIDs can make the skin more sensitive to the sun, so it's important to think about sun protection. And this would be true for any of the medications that we talk about for treating juvenile arthritis. The most common side effect of an NSAID would be that they can bother the tummy. For some children, this presents as stomach ache or burning. Other children might have constipation or diarrhea. This doesn't always happen, but it can happen, so it's important to be aware. We talk about taking the medication with food to try to prevent some of the maybe tummy ache or burning. And we often suggest that constipation and diarrhea can be managed with dietary strategies. Some children can have the other side effects of headache, tiredness, or change in mood. Often, if we just continue a little bit, these side effects will resolve on their own. And if they don't, it's important to speak to your healthcare provider about them. There are times when you should not give an NSAID. So we're saying taking it regularly is going to be what's going to help with the arthritis. But if your child is vomiting, for example, they have a gastro, or they're not eating for some other reason related to illness, it's important not to give the NSAID because it can really bother their stomach more. If a child has chickenpox, we wouldn't give the NSAID either for the period of time that they're unwell, because it can cause an important skin infection. It's always important to remember that once the illness has resolved, you restart the NSAID. So when would you speak with your healthcare provider? We've already said that tummy pain that isn't managed by taking the NSAID with food. If a child has blood in their stool or their poo or black stool, it can be a sign that the stomach is irritated and you need to speak with their healthcare provider. If they need surgery, they may have to stop their medication for a few days on either side of the surgery, so your healthcare provider will help you to understand that. Sometimes children can have other symptoms that are worrisome that may or may not be related to their treatment. So again, it's important to discuss with the healthcare provider in order to understand what's happening and to try to find appropriate solutions. The next step of medications is a class of medications that we call DMARDs, or disease-modifying antirheumatic drugs. As Dr. Carlo Mango said, when there are many joints involved or when the arthritis persists despite treatment with an NSAID, methotrexate, which is a common DMARD, is the next most commonly used medication. Methotrexate has a long record of safety and effectiveness in treating arthritis in children. In high doses, methotrexate is used to treat cancer, but in low doses like we use in arthritis, it treats the arthritis, uveitis, and other autoimmune conditions. There are other DMARDs that are part of the family, but they're used less often than methotrexate, so I won't talk about them today. Methotrexate works by, like Dr. Carlo Mango said, by slowing down a pathway in the immune system, decreasing inflammation in the joints. So we've talked about why it's added. Dr. Carlo Mango already mentioned it's given once a week. We always let families know because sometimes kids, if you're giving it on a Friday evening, sometimes that's also an important family time, maybe a family dinner, or children might have activities or outings. So it's important to know that you can change the dose by 1 day. So it's always important to allow 6 days between doses. But if your child has an activity and it's difficult to give them their methotrexate on the usual day, you could do it a day earlier or you could do it a day later. Methotrexate can be given by pill form or also by subcutaneous injection, which means under the skin and into the fat with a needle. Many rheumatologists prefer to give by subcutaneous injection because the methotrexate is more completely absorbed. This is something that we as nurses teach caregivers to do and can be managed by family members at home. I've mentioned folic acid here. I always say that folic acid is the friend of methotrexate. You always find them together. It's a B vitamin, and it helps to prevent some of the common side effects of methotrexate. We always talk about alcohol because sometimes teens are wanting to have some alcohol. And it's just important to remember that methotrexate and alcohol are both cleared from the body by the liver. And so it's important to make sure not to cause any irritation to the liver. So for young persons wanting to have some alcohol, it's important that they discuss this and get recommendations from their healthcare provider for when and how much is acceptable. Methotrexate can damage a developing unborn child. So birth control is needed for teens who are taking methotrexate. Taking methotrexate won't affect a young person's ability to have a child later in life. Vaccines are important to provide protection against common infections, and many vaccines can be given when a child is taking methotrexate. However, there's one group of vaccines that should not be taken, and I'm going to talk about this a little bit more later. As Dr. Carlo Mango said, methotrexate can take a little bit of time to work. Some children start to feel benefit after 2 to 3 doses, but the maximum benefit can take longer. When your child goes to visits with the healthcare provider, what they're looking for is they're looking for a gradual improvement over time. The most common side effect of methotrexate would be tummy upset or nausea. There's a lot that can be done to prevent and to manage this tummy upset that can occur around the time of taking methotrexate. I'm going to suggest that we talk more about this in the question and answer if this is an interesting topic to you. Taking the vitamin folic acid can prevent the next 2 side effects, the sores in the mouth and the fatigue. Also, taking methotrexate at bedtime and on the weekend can be helpful if your child is having fatigue after their methotrexate. Because the methotrexate works on a pathway in the immune system, sometimes we worry that the child might get sick more often. But we don't always see this. But like other children, those on methotrexate will sometimes get colds. They could get ear infections or other illnesses. So when your child does have an illness with a fever and symptoms that last for more than 48 hours with no improvement, they should see a healthcare provider. We talk about preventive strategies for common infections like good hand washing before meals and snacks, having a yearly flu and COVID vaccine, and making sure that other vaccines are up to date. Children should absolutely go to school and be part of usual activities with their friends. Again, there's a time when it would be important not to give the methotrexate. So if your child is unwell with a fever or they're needing an antibiotic, this means that their immune system is trying to fight something off, and it's not the time to give the methotrexate because the methotrexate quiets a part of the immune system. So you might need to skip a dose and restart the following week when the child is better. Again, if a child is vomiting, so they have gastro, it's just not a good time to take a medication. And we talked already about planned surgery, that sometimes the methotrexate might need to be held for a dose before surgery or after surgery. So again, talk with your healthcare provider. We've already talked about the first two parts, so I'll just go directly to vaccination. I'd like to talk a little bit more about vaccines because it's very important. There are two basic kinds of vaccines, and the first kind I'll talk about is they're inactive or killed vaccines, are two different names for the same thing, and they can be given to a child even when they're taking methotrexate. The other category of medications where we need to be careful is the ones that we call active or live vaccines. So again, two names for the same thing, just to make it a bit more complicated, but those are the ones that we need to watch out for. So active or live vaccines use a weakened form of a virus to make the vaccine. And for most people, this causes no problem, and this kind of vaccine gives really good protection against disease. When a child is receiving a medication like methotrexate, the concern is that they might respond too much to the vaccine. They'll be protected, but they might get some symptoms of the illness as well. So we avoid this kind of medication, or we try to give it before they start taking methotrexate. This is a bit complicated, so you may not remember all of this. The important thing is to speak to your healthcare provider if your child needs vaccines while they're taking methotrexate. I'll just go next to the list. You can see here a list of vaccines that are active or live. And many of these vaccines, you can see from the list, will have been given when your child is little, like at 2 months, at 4 months. So often before the onset of the juvenile arthritis. Some, like the flu vaccine, polio, and typhoid vaccines, are available as active and inactive vaccines, and they're a good option for a child who needs them. Go to the next step for medications. So the last step would be biologics, or we sometimes call them biologic DMARDs. They've been used in Europe since 2000 and in North America since 2003 for treating arthritis in children. There are different categories, and your healthcare provider will choose the one that's suited for your child. Biologic drugs are divided into categories based on where in the immune system they work. They're very specific, and they target a specific part or pathway in the immune system, again, to stop inflammation, to get rid of joint pain and swelling. So why do we add them? And Dr. Carla Mango talked a little bit about this. I'll just reinforce or add to that. Some children may improve with NSAID and methotrexate, but still have active arthritis. Some children may not do well on a certain medication. They may have side effects that make that medication difficult to use. And some arthritis conditions like systemic JIA respond best to a certain kind of biologic, and it may be used early in the treatment. So those would all be reasons why a child might need to add this kind of medication. They're given by 3 different ways: by subcutaneous injection, which again means a small needle under the skin and into the fat, or by infusion, which means through a tube and into a vein, and some are given by mouth. How often they're given depends on the type, so it could be every day, It could be every week, every 2 weeks, or every month. When the biologic is given by subcutaneous injection, you might have a little reaction around the injection site, so maybe a little bit of redness, itchiness, or swelling that just tends to go away in the next day. Some children may have a bit of fatigue after their treatment, but others might feel more energy because they start to feel better. And the same as methotrexate, children may not get sick more often, but when they do become unwell, it's important to see the healthcare provider for persistent symptoms. Again, there's times when we would not give a biologic medication. So if your child has fever or antibiotics, the same way as methotrexate, the planned surgery. And I've written here, pay attention to skin infection, because skin infections, like we always give the example of a little tiny ingrown toenail with a little bit of redness and pus, can become really important if it's not taken care of. So just watch for things like that in your child if they're taking a biologic. And again, it's the same as for methotrexate, so I won't repeat it, but these are times when it'd be important to speak with your healthcare provider. I've talked about 3 categories of medication that are helpful to manage arthritis. There's often a time of waiting for medications to work, so it's really important to have some strategies that help with pain and movement while you're waiting. And you probably have lots of experience with this, and I'd love to hear about what you do during the question and answer. And I just have a few ideas to offer you. Warmth is really helpful for a painful, stiff joint, especially in the morning or after a period of inactivity. The warmth helps the joints and the muscles and tendons around the joints to relax and move more easily. Warmth can be applied with a magic sack heated in the microwave, with a heating pad, with a warm cloth, in a shower or the bath. If your child likes massage, it can be a way of relieving tension from pain or from holding a joint in a specific way. Physiotherapist or your healthcare provider will give exercises to help increase the movement of joints that are affected. And even though these are sometimes difficult to do, they do help to decrease the pain and the stiffness. Okay. So Dr. Calamango talked about doing blood tests. So I'm not going to repeat what she said. When we do blood tests, to check either for disease control or check that a medication is tolerated, some of the more common tests that are done are the CBC that she talked about, liver enzymes, which would be AST and ALT, and kidney function. So those are all really important for making sure that the medications that your child is taking are well tolerated, and that there's no adjustments needed in the treatment. I always say, kids say it would be a normal thing to say that they don't like blood tests. I don't think anybody likes a blood test, and it's really important to pay attention to helping children manage this challenge. So we often use numbing cream to the area where they're going to have the blood test. Warmth to the area can help if you don't have access to numbing cream. It's important for a child to have choices. Do they want to sit down or lie down for the blood test? Do they want their right arm or their left arm? Distraction is really important. So whether it's telling a story, looking at a video screen, or whatever else it is that the child would like to do during the blood test to help them. We use something sometimes called a buzzy bee. And if you want to know more about that, you could ask me during the question and answer. Dr. Calamango also talked a little bit about uveitis and why it's important for uveitis to have eye exams with an ophthalmologist or an optometrist. And she mentioned that uveitis, so uvea being the front part of the eye, itis being inflammation, is a part of juvenile arthritis. So it's really important to check that there's no uveitis present, because unlike with the joints, the eye doesn't get swollen, it doesn't get red, it doesn't hurt. I'll let you go ask for the next slide. If uveitis isn't detected, it absolutely can affect the vision. How is it detected? The optometrist or the ophthalmologist will use a special, will look at the back of into the eye with a special tool that they have called a slit lamp. So it's called a slit lamp exam. It's not difficult to do. It doesn't hurt. It does use a bright light. And the good news is that if uveitis is found, it can be treated. Often the treatment starts with eye drops. And some of the medications like methotrexate and the biologics can also be really helpful for managing uveitis. Dr. Carlo talked about those who are most at risk, so I won't review that. I've written for you a few websites that I think might be helpful to you, that I find helpful. And I want to thank you for allowing me to share information with you, and I look forward to hearing from you in the question and answer.
Thank you. Thank you so much, Charlene. And thank you to all our speakers for the wonderful presentations. So now I'm going to open the floor for a few questions. Maybe we can do 3 because of time. Yes, Paris.
So I had a question. Thanks, Tracy, for the opportunity to ask a question. I had a question regarding genetics and arthritis. Is there any tangible, maybe data or experience in the past where a parent who has arthritis easily transfer it to the children?
I think Dr. Angela can take that.
Yeah, Paris, that's a good question, and I'm often asked that in the clinic quite a lot. And what we know for most of our diseases in rheumatology, including arthritis, yes, there is a genetic risk, and in the presence of a potential environmental trigger, that can make the child or even the adult develop the disease. However, the genes that are involved are so many, right? And so I can't quite say because the mother had arthritis, she will pass it on to the child. However, as my colleague, Dr. Calomagno, had highlighted, there are certain genes we can test for, like the HLA-B27 gene. And that one, if we find it's positive, we can even predict for you which joints are likely to be affected and involved. That notwithstanding, Paris, we still have a lot of work to do in our setting to do research and see what is the genetic map for our cohort of patients and see if there are any patterns. But to answer you, I can't quite say because father has arthritis, mother has arthritis, then the child will get arthritis. But that genetic risk can be passed on. But there's more than just a genetic risk involved before you present with the disease. And our environment does play a big role. I hope that answers your question.
Yes, thanks.
Thank you. Thank you so much. So there's a question that has come in the chat. Does some of the JIA medications affect the menstrual cycle in adolescent girls? So between Charlene and Dr. Faela, I think one of you can take that.
I can take that, Tracy. Thank you. So this is a very good question. Thank you for asking. As Charlene was saying, it is true that we have to be careful with girl on medication, especially with methotrexate, because this medication can affect a child in the uterus. So this is one thing. But another thing is if this is, and this is the question is a little bit different, if the medication can affect the capability of being sterile, of being fertile, of having children. And this is usually not the case, although I have to say that the inflammation, constant inflammation, chronic inflammation, so the disease that is not well treated, this can reduce the menstruation cycle, for example. So it's almost on the contrary. But we have to be care for these girls and be attentive that they not get pregnant during medications.
Okay, thank you, Dr. Rafaela. So I'll give room for one more question. Stanley? Stanley, you can unmute.
Question is about physical exercise. A child who is taking a medication, and also, yeah, child who is taking medication, can he or she do exercise? And exercise, can it help to recover from arthritis?
Doctor?
Maybe Charlene can comment on that.
Okay.
Before I comment.
Sure. I mean, a child who's taking any of the medications, so the NSAIDs, the methotrexate, or the category from biologics, they can absolutely do exercise. If they're sporty kids, they can do sport. Sometimes when the joints are really swollen and painful, they may not be able to for a while, but the idea is to control the arthritis and to get them back to the activities that they like. So movement is really important for the joints in terms of having good movement, and doing activity can help with that. And sport brings pleasure to kids. It's great for their social development. So absolutely, they should be doing their activities that they enjoy.
Thank you, Charlene.
And Kelly, just to support what my colleague Charlene has said, the sessions we are having next week, Saturday, is going to be focusing on that, the non-medication interventions. And we have a whole session on just the importance of physical activity. So please save the date and diarize it, and you hear from our mental health experts and other healthcare professionals on their role. Thank you.
Okay, thank you. So thank you for all the questions, and a huge thank you again to our incredible speakers for sharing their knowledge with us today. So I'll just like to remind you a few things. One is the post-course assessment, which I've just shared in the chat. Kindly take a few minutes to complete the course assessment so that we can continue improving our programs. And then, as Dr. Angela has mentioned, we have part 2 of the JIA Masterclass next Saturday. We'll talk more about exercise for JIA patients. We'll also touch on mental health and the role of support groups. So for those who joined late, we also mentioned that we shall be issuing certificates to the participants who successfully complete this course. And for you to receive this certificate, you have to meet the following requirements. First is take the pre-course assessment for both sessions. Then secondly, attend the live session today and the next one on Saturday on 21st. Then also complete the post-course assessment for both sessions and also the general feedback form. And also, I would like to invite you to join our WhatsApp community to get timely updates and learn more about our programs and the resources that we have available. I have already shared the link with you on the chat. And we also have our virtual academy, which we launched on 9th September. So the link has also been shared in the chat. So feel free to peruse our academy and see other courses that we have. We have courses for healthcare workers. We have courses for guardians as well. And we also like to call on you to help us in this journey. So if you would like to support us, we have also posted a link there for donation. Any contribution, big and small, will really go a long way to help us champion for children with arthritis. And so with that, we have come to the end of our session, Hope and Healing Masterclass Part 1. So stay tuned for more upcoming events and learning opportunities from the Hope Arthritis Foundation. And in case you have any questions or you need support, don't hesitate to reach out to us. So thank you so much. Have a great weekend. Have a great day. Check out our website. If you have any questions, you'll find our contacts there. So if you connect with us, you'll be able to link up with the speakers and follow up in case there's still something that is not clear. So thank you so much, everyone. Thank you for your time and goodbye.
Bye-bye.
Bye.
Thank you.
Bye-bye.
Bye-bye.
I see you.
Bye.
Bye. Tracy, you can put the audio and slideshow as people exit, if it's
Sorry?
possible. You can play the audio and the slideshow as people exit, if it's possible.
Okay.
Mm. So, thank you, Colleen and Rafaela. Thank you so much.
Thank you. I don't know if you wanted to meet after or no need. I was waiting.
Yes, I don't know whether yes.
Oh,
Tracy,
yes,
are you
recording. Oh.
Tracy,
I
are
didn't
you
get the
able
audio.
to? No,
Okay, I don't know what
no.
has happened to it.
Okay. Okay. All right. I don't know, Tracy, whether you're able to assist our other participants to vacate, and then we can remain with
Okay,
Charlene and Rafaela.
okay.
Good. So you can stop recording.
Okay.
Thank you.